Joint Ventures. In this OSC original podcast, we look at recent medical news from an orthopedic and pain management perspective to help you understand and apply it to your health. I'm Dr. Jenny Andrus, and I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. Post-traumatic stress disorder has been in the news consistently for the last few decades, really, and we're quite familiar with it here. It's the most common behavioral health diagnosis to go along with chronic pain. The relationship between post-traumatic stress and chronic pain is complicated. Sometimes post-traumatic stress is a risk factor for developing chronic pain, and sometimes the experience of severe chronic pain or the event that started the chronic pain results in post-traumatic stress symptoms. So we're fortunate that our in-house psychologist, Dr. Andrew Martin, who's joined us today to discuss, is an expert in the diagnosis and treatment of post-traumatic stress.
Post-traumatic stress treatment evolved quickly over the last 2 decades. Advancements include shorter, more comfortable treatments with higher success rates. It's resulted in a move away from medication and toward psychotherapy as the first-line treatment. Examples include Edna Foa's prolonged exposure therapy, Patricia Rezick's cognitive processing therapy, and Francine Shapiro's eye movement desensitization and reprocessing therapy, to name a few. We've also learned that certain medications like benzodiazepines should actually be avoided when treating PTSD because they can make symptoms worse and slow down the treatment response. We also now know that you can't treat traumatic stress symptoms the way you would treat anxiety or depressive symptoms. You have to treat them specifically as trauma symptoms. For people who suffered with anxiety and depression all their life despite treatment, it's sometimes because what they're really experiencing is traumatic stress.
Well, we've talked about this in previous podcasts, but I think it would be helpful for you to briefly review the relationship between behavioral health symptoms and chronic pain before we dig into post-traumatic stress specifically.
So the first thing I always tell folks is the brain cannot create pain, except in very rare cases like phantom limb pain, phantom breast pain after a mastectomy. The brain can intensify pain that's already present in the body. So untreated or undertreated anxiety, depression, traumatic stress symptoms, those put a stress on the brain that makes it involuntarily focus on threats more, like chronic pain. It's nobody's fault. It doesn't mean that the pain is made up or not real. It's all real. And the good news about that is that that means that some of our pain might be controllable by addressing emotional pain.
You sometimes come down the hallway all excited because someone we referred to you for traumatic stress symptoms you found, and you're not excited because they have the symptoms, but you think you're really able to help that physical condition by addressing those trauma symptoms.
Yeah, absolutely. That's the best part of the job, is helping somebody with emotional pain and then having them say that their physical pain has reduced as well.
For sure. So PTSD is a complicated diagnosis with a lot of different moving parts. One of the questions we get is, how do I know if I have post-traumatic stress?
Yeah. Well, we might not know. One of the things about post-traumatic stress and behavioral health diagnoses in general is that they can be difficult to self-diagnose. We become used to the symptoms, and so we don't notice them. They're unpleasant, so the brain denies them at times. And with post-traumatic stress, the brain tries not to think about anything connected with the trauma. And that might include our thoughts, feelings, and memories about the trauma.
And I wouldn't recommend self-diagnosing behavioral health conditions anyway. You want a medical professional like your primary care provider or a mental health specialist to do that, because it actually can be quite tricky. Starting with primary care is always really a smart choice because some medical conditions can mimic behavioral health symptoms or exacerbate them, and you might miss something that can or should be treated medically.
Yeah, we rely on physicians to help us rule out medical causes of what seem like depression or anxiety. That said, the signs of traumatic stress diagnosis fall into 5 categories. The first is exposure to actual or threatened death, severe injury, sexual violence, either by experiencing the event, witnessing the event happening to others, learning the event happened to a loved one, or being exposed to details of traumatic events repeatedly, like police officers who often have to see the signs of child abuse and neglect.
And the traumatic event doesn't have to be a dramatic one. We're learning that trauma symptoms can result from more subtle or chronic traumas like abusive or neglectful relationships, and that those traumas then can sometimes result in more complicated forms of traumatic stress. So, in other words, you don't have to be a soldier to develop legit traumatic stress. It can happen to anyone exposed to a major or chronic stressor.
Yeah, I'm glad you made that point about you don't have to be a soldier. And it's rare, but I still get a few people who think their symptoms aren't valid because they were never in combat. I've treated this condition on active duty and as a civilian. It can happen to anyone. And sometimes that way of thinking about post-traumatic stress is actually the brain's attempt to deny that anything actually bad happened to us. It does this by comparing traumatic events with other people's events. But the event is just one part of the experience, and reactions vary considerably between people. We no longer recommend mixed therapy groups with sexual assault survivors and combat survivors because of this. It often devolves into one group using the other's trauma to try to minimize their own trauma. It's pretty common. All trauma is traumatic. The second category of post-traumatic stress symptoms is intrusion symptoms, or unwanted changes to behavior, feelings, and thoughts following a trauma. They include distressing memories and dreams, flashbacks or feeling like the event is happening again, or emotional or physical distress when I'm suddenly reminded of the event.
Now, this sensitivity to memories and thoughts about the traumatic event can be pretty intense, and the brain tries to avoid it if possible. And that's one of the hallmarks of post traumatic stress: avoidance.
Indeed. It's normal to find oneself avoiding memories, thoughts, and feelings associated with a traumatic event, as well as related people, places, conversations, objects, or situations. Sometimes we don't even notice the avoidance is going on. It's actually a spouse that points it out. We just notice that we don't feel like leaving the house anymore, or we don't feel like engaging in certain activities. But thankfully, the people around us do notice and get us to go for help. The next category of symptoms is negative changes in thoughts and mood. This is a little different from the intrusive symptoms where we experience our own thoughts and feelings as intrusive. These symptoms look a little more like classic depressive symptoms and include difficulty remembering important parts of the trauma. Being dominated by negative beliefs about oneself, others, and the world, or distorted thoughts about the cause of the traumatic event, usually focused on blaming other people or blaming ourselves.
So, like when someone is sexually assaulted and then they start thinking they wore the wrong dress or they shouldn't have been drinking or flirting, as if those things caused the assault.
Exactly. The brain wants control, and for control, it needs something or someone to blame. The negative changes to mood include persistently feeling afraid, horrified, angry, guilty, or ashamed throughout the day. There's often a loss of interest in activities, feeling detached or estranged from those around us, and an inability to experience positive emotions like being satisfied, happy, or feeling loved, even for brief periods.
What about dangerous behavior?
Okay. So dangerous behavior is pretty rare with post-traumatic stress, but being wired and irritable is pretty common. The way people usually describe that irritability to me is they say that they are getting angry for no reason. Sometimes they say they're acting in reckless or self-destructive ways, or they're hypervigilant. Hypervigilance, that's being too on guard and wary.
Like having to sit with your back to the wall where you can see all the exits.
Right, right. And we may find ourselves startling very easily or having difficulty concentrating. It's like we're in fight or flight mode all the time, including at night when we have difficulty sleeping.
Okay, so that is one complicated diagnosis. How about, let's go basics: onset, prevalence, duration.
Yeah, it is complicated. And for that reason, I find patient self-report questionnaires very helpful in finding all of the symptoms. So, post-traumatic stress symptoms can begin immediately following a traumatic event, or they might be up to 6 months or longer afterwards. Post-traumatic stress is common. About 6 to 8% of people experience post-traumatic stress in their lifetime. As far as duration goes, about half of the people with PTSD recover with no treatment in about 3 months' time. Because post-traumatic stress can go away on its own, we don't even really diagnose it until the symptoms have been present for at least a month. And then before that, we call it acute stress disorder. Same symptoms, just within a month of the traumatic event. And it can also last a lifetime. And I have several patients who've had PTSD for 50 plus years. And it's really cool to see people finally get rid of 50-year-old symptoms.
That's a long time. So, a lot of people don't know that PTSD can be cured. I said cured, yes. They think you have to learn how to cope with the symptoms or to avoid your triggers. But successful PTSD treatment gets rid of all that stuff, so you don't have to cope or avoid. And I know it's a big question, but can you talk a little bit about what treatment does?
Sure. So most successful trauma therapies include exposure or facing the traumatic event. This can include telling the story, but not always. The exposure needs only last long enough to make sure any trapped feelings from the event can finally run their course and be done with. The second most common element is cognitive restructuring or thought changing. This is where we learn to see our thoughts that may have been disrupted by the trauma, even the unconscious ones, analyze them, and then tweak them so we can think about the trauma in as realistic a way as possible. This part is crucial for getting rid of anger, guilt, and fear. And finally, some treatments include a full checkup on certain themes of thoughts that are often disrupted by trauma. These include how we see ourselves, others, and the world in terms of safety, trust, power, control, esteem, and intimacy.
So, how about the effectiveness and any risks associated?
Okay. So most trauma therapies are about 70% successful, meaning 70% of patients have their symptoms go away completely, long term, or reduced to the point where they no longer cause interference in their daily functioning. There are no risks associated with trauma therapy. The hardest thing about trauma therapy is going to the first session, and it's never anywhere near as bad as what people think it's going to be.
I bet. So, the takeaway here are that PTSD can happen to anyone, unfortunately. It's a normal reaction to an abnormal event. And when seeking treatment, it's important to find trauma-focused psychotherapy. If you ever want to know what treatments are most effective for a condition, search clinical practice guidelines and the condition, and then you'll find a summary of all the research out there on treating that condition. Thank you so much for joining us today. Please like us, subscribe, and share this with your friends. Wishing you good health. See you soon. Bye-bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.